Hello, welcome to Safe Work Practices during the ongoing COVID-19 pandemic. This webinar is brought to you by the Southwest Center for Occupational and Environmental Health, a NIOSH Education and Research Center at UTHealth School of Public Health. My name is Michelle McDaniel, and I am the Director of Outreach and Continuing Education for the Center, and also moderating today is Dr. David Dufrate, Associate Professor and Industrial Hygiene Program Director. This web event is part of the Greater Houston Industrial Hygiene Council, which we facilitate, and traditionally is a bi-monthly live in-person meeting of industrial hygiene and safety professionals that discuss emerging issues and best practices in occupational safety and health. In the past, we usually meet on the UTHealth campus, but given the precautions taken during the COVID-19 pandemic, we're now moving into an online space, and today have a virtual session with a great lineup of experts. First up is Dr. George Delclos on COVID-19 overview and current trends. And Dr. Delclos is a professor and deputy director here at our center and medical director of employee health at UTHealth. Next, we have Mr. James Shelton on COVID-19 regulatory guidance. And Mr. Shelton is a compliance specialist at the OSHA North Houston office. Then we have Lynn Sessions and Ashley Grant, who are both partners at Baker Hostetler, who will be discussing COVID-19 labor and employment. And then is Dr. Christina Mena on SARS-CoV-2, the #1 pandemic driver. And Dr. Mena is Associate Professor and the El Paso Campus Dean for UTHealth School of Public Health, El Paso. Lastly, but not least, is Dr. Matthew Noneman on SARS-CoV-2 sampling considerations. And Dr. Noneman is Associate Professor at the University of Iowa College of Public Health. So for those that attended the live event, if not already done, please make sure you completed the evaluation using the email sent to you, using that link within that email as to provide feedback and gain your certificate of attendance. So now we are going to turn it over to Dr. Delclos.
Use some basic principles, but I'm just going to describe the different tests available, the pros and cons, and then we'll open it up to question and answers if that's okay with everyone. So first slide, please. So the New York Times is a very good resource for daily numbers, and this is as of yesterday, although the rest of my slides are as of today. The picture worldwide is that we are nearing 40 million cases and over 1 million deaths. In the United States, we are almost at 8 million cases, and that represents, we're now above 50,000 new cases a day, which represents a 21% change over the last 2 weeks, so in the wrong direction, up. And at the same time, though, deaths, even though they are increasing, appear to be stable in terms of the rate of increase at around 216,000. Next slide. The devil's in the details, though. For Texas, these numbers are a little bit more encouraging. The overall number of new cases in Texas for the last month or so had been relatively level in terms of rates of change, although in the last week they are starting to creep up again. At the same time, though, fatalities, rate of change of fatalities, has been going down. So that tells us a lot of things. It points to who is more likely to get the infection. It's typically going to be groups that are younger and that are not as prone to dying from COVID, even though that doesn't mean that they are immune from COVID, from dying from COVID. So we'll take a closer look at this in a minute. Next slide. Those state numbers vary, of course, from county to county and city to city. If we look at the same number of daily cases for Texas and the line indicates the 7-day moving average, and we plot them on the different reopening and then closing measures that have been implemented ever since March 1. We see that certain measures have been associated with important increases in number of cases. So, for example, in March is when we started counting, but really the shelter-in-place order for Texas didn't really start until April 1. And you notice that over the next 2 weeks, and every time you make an intervention, you've got to wait about 2 weeks, which is the maximum incubation period between exposure and development of disease, so that you can see if that intervention is having an effect. So on April 1, the shelter-in-place was enacted, and that was because the number of cases had started taking off. And you see that in the subsequent 2 weeks, that leveled off, that rate of increase. And then on May 1st, the governor began phase 1 of reopening, which was just very few things, minimal reopening of restaurants to less than 25% capacity, and things like that, curbside delivery for supermarkets, etc. And that didn't appear to have much of an effect on increasing cases. They were still level, but in mid-May, the phase 2 reopening, which allowed more restaurants to open, even some bars to a certain extent, began. And you can see that starting at around June 1, at about the 2-week mark, there was a rapid increase. It also coincided with phase 3 of his reopening, dramatic increase. And we faced in Texas what has been the biggest and the worst surge in cases that lasted throughout the month of June and the better part of July before we started seeing a change and decreases. And that was because some measures some of the reopening measures were put on pause. And so the numbers began to decline. And in September and October, we've never gotten really back to our baseline, but they did level off, and that led to some more reopening in the last couple of weeks, with restaurants now up to 75% capacity, bars just being allowed to reopen as of a few days ago, and we will see where it goes. But look at the tail end of that 7-day moving average. You see after October 1 that it's starting to creep up again. We'll look at it in more detail here in a few slides. Next slide. There are important parameters to follow when you're looking at rate of change of disease and whether the infection is spreading or not. And one of these is what's called the RT estimate. Some people call it the R naught value. Basically, an R naught value of 1 means that an infected person is likely to infect, on average, one other person. If the R naught is less than 1, that means that one infected person is likely to infect very few other people. And if the R naught is 2 or 3 or 4, the higher the R naught value, the more number of people on average that a single case can spread the infection to. You'll see that as of the most recent data in Texas, we are at an R naught value of 1.09. That means we're a little bit above 1. So that anything above 1 favors spread. Last week, we were below 1. So we need to look at these changes in R naught values because they are harbingers of the spread. So going above 1 is not good. It's not as dramatic as at the very beginning when it was 2 or 3, but it's not going in the right direction. Next slide. Now, some people say, well, we're having more cases because we're testing a lot more. And it is true that we are finally testing a lot more. Still not where we should be, but a whole lot better than we were several months ago. Our biostatisticians at the School of Public Health at the University of Texas have developed a dashboard that I would encourage all of you to take a look at when you get a chance. The website is called www.texaspandemic.org, all one word, and they plot some very interesting statistics. One of the things that they have been following since the very beginning is this issue of whether increases in cases are due simply to more testing versus an actual true increase. And so what you see, the blue line tells us the number of tests. This is over since about July, and you'll see that there's been a slight but steady increase in the availability of tests and tests that are performed. The orange line, on the other hand, indicates the number of confirmed cases, so the number of positive tests. And you'll see that at the very beginning and at the end, the lines are almost parallel. Parallel means that a good portion of the increased number of cases is it can be attributed to testing. But when the increase in the slope of the orange line is greater than the slope of the blue line, of the testing line, then that means that your number of positive cases is exceeding the introduction of the number of new tests. And that's not good. Conversely, when it's going in a down direction, that means that we are testing more than actual cases that we are detecting, which is a good place to be. And we were in a pretty good place in around the middle of September, but note that that orange line is starting to creep back up again. The next slide, please. So what I presented now are just simply up until now, are average cases for the state of Texas. But it's always important to remember that there is a lot of variability in cases across the state. As Dave Dufresne said, Texas is a big state, and there is tremendous change county by county in terms of whether rates of cases are increasing or decreasing. One of the measures that we look at is the test positivity rate. That means out of all of the tests that you perform, what percent of those tests are actually positive? And when test positivity is high, that means that you're going in the wrong direction. When test positivity is low, and as a rough rule of thumb, we like to see test positivity rates at or below 5%. Then things are under better control. We'd like to see for it to be 0%, but it does indicate that things are in reasonable good control. So what you see on this map is the tremendous variation there is in test positivity rate. Everything in green are counties that as of yesterday have good test positivity rates, below 5%. What you see in the yellow, slightly orange, means that it's close, it's just barely above 5%, and in red is markedly above 5%. And in some places, the test positivity rate may still be reaching, like, for example, the Lubbock area, et cetera, may be reaching well over 10, 15, or even 20%, which basically tells you there are a lot of cases and we're not testing enough. So, again, overall numbers for Texas is one thing, but then the devil's in the details. You got to get granular and see. And one of the things I do emphasize to everybody is, we hear all of these world statistics and U.S. statistics and Texas statistics, but at the end of the day, for you, what matters most are the rates in your local area. So, we take a look at Harris County in the greater Houston metropolitan area every day, because, as we'll see in a minute, our numbers lately are not too bad. Next slide. And the reason it's important to look at your local numbers is because those local numbers are going to drive the measures that are implemented both by the county health authorities, the city health authorities, and actually a lot of employers can avail themselves of what's going on in their community to make decisions with respect to their own business. So these are the data on test positivity rate for Harris County, and this goes back to several months. You'll see that in Harris County, it tended to parallel what was going on in the state, with increases in between March and April, then a decrease, and then a marked increase in July and June, latter part of June, July, and then spilling into August. And then since then, there's been a steady decrease. So right now in Harris County, our test positivity rate is around 6%. That's not where we want it, but it's better than 10%, right? So, so we still have some work to do, but as of yesterday, we were at 6%. The problem is that the trends are projected to change, as we'll see in a minute. Next slide. Talking about looking locally in Houston, particularly, I take a lot of close looks at what is going on in our medical center, the Texas Medical Center, which really houses a number of health systems that also have hospitals that are outside the physical location of the Texas Medical Center and are all over the greater Houston area. And so, for a number of months, the Texas Medical Center, this consortium, has been following a set of key indicators. Up until now, I've just been giving you numbers of cases, positivity rate, deaths, but there is a very important aspect that I have not mentioned until now, which is hospital capacity. We've all seen the stories of what happened in Europe, in Italy, and in Spain, and to a certain extent in Washington State and in New York, when hospital capacity was stretched very, very thin and had difficulties accommodating patients with COVID that needed to be hospitalized, and especially those with the most severe forms of the disease that needed ICU care and maybe even mechanical ventilation. Resources were stretched incredibly thin. And it's not only material resources like numbers of ventilators or beds available. The other important resource is sufficient healthcare workers to man those ICUs and those ventilators and those hospital beds. And so when they are stretched thin, the quality of hospital care falls, death rates and complications increase. So at the TMC, we follow a combination of local statistics as well as hospital or health system specific statistics. And as of 2 days ago, probably should have updated it for yesterday, but if we look at, one of the things we look at is the R0 value, the RT value, and you'll see that for the greater Houston area, it's 1.16. Remember that I said it was 1.06 for the state. So that's something we need to keep an eye on, because our test positivity rate locally is a little bit higher than the state average, and it's above 1, which means that the virus is spreading. And more worrisome is the comparison to last week. Last week we were below 1 at 0.98. And that means that one person spread it to less than one other person on average, and now we're above that. So that's an indicator that that we need to keep an eye on. We also look at our own positivity rate. Remember that I said that for the Houston-Harris County, it's around 6%. In our hospital systems, it's actually lower than that. It's about 3.8%. That means that even though cases are increasing in the community, our hospitalizations have remained reasonably low over the last few weeks, which is good, because that means we have hospital capacity to confront any surges that appear. In terms of the greater Houston area testing positive, as of the 13th, there are about 670 new people, and that compares to that's a big increase from the previous week, 412. It's better than last month, but it's a significant increase from last week. So that points to some things that are concerning, that we may be, instead of turning the corner, we're turning the corner in the opposite direction. We're going back, and we may be seeing the start of a surge. With respect to hospitalizations, even though they are still low, as I said, nonetheless, they are greater than they were last week. So the entire Texas Medical Center on the 13th had admitted that day 102 new cases of COVID, and in the previous week it was only 86. And ICU capacity, though, has remained good. We're at 89% full, and that means all patients, not just COVID patients. What we look at is as an indicator is whether COVID patients are occupying more than 15% of the ICU beds. And as of a couple of days ago, we were at around 13 or so percent. So that's just the base. We're at baseline capacity, which is good. There are several surge plans in place that we have had to activate in the past, especially in July when the surge was huge. And that means that these are measures that hospitals take to increase their availability of ICU beds by converting other beds into ICU beds, by moving things around, by not allowing elective surgeries, which free up surgical beds and beds in the surgical ICU, et cetera. Right now, we're in phase 1, which is business as usual, with plenty of capacity to absorb increases in case of the future, as long as those increases, are not huge and start stretching our resources. With respect, I didn't put it up here, but another very important indicator for health systems is the availability of PPE. We cut it very, very close in April and May. We started implementing a number of measures to conserve PPE, even shattering things like longstanding OSHA norms, like making N95s not single use, or looking for ways to prolong their use, advising the use of surgical masks, which used to be a no-no as respiratory protection. They're really more barrier protection, as you all know. But restricting who gets an N95, et cetera. And those measures really worked. One thing that helped tremendously in the medical center was the availability of disinfection systems for N95s. Again, another no-no, from the past, but we've had to become very innovative. And so one of the things that we did when it was very difficult to buy N95 masks, the hospitals, and hospitals use thousands of N95s every day. So one of the things that we were able to do is to use vaporized hydrogen peroxide as a disinfection system, a dry disinfection system for N95s. And all of a sudden, that extended the use of an N95 from one use, one person, to 15, and some studies have even showed up to 30 times you can reuse the same mask if you disinfect them that way. Well, all of a sudden, if you weren't able to buy new N95s, you just multiplied your availability by a factor of 15 to 20 to 30, simply on the basis of this disinfection technique. So we have measures in place. There's a lot of PPE available now in Texas in general, but especially in the Harris County area. So I think we know how to handle it, and our past experience is also going to model how we are able to face any upcoming challenges. Next slide. So that's the situation now, and I want to spend the next several minutes talking about what's around the corner. Now, there are a number of reasons to, you probably heard the public health authorities, Dr. Anthony Fauci, the CDC director, Dr. Redich, come on television and say that they are very concerned about November and December, that we may be seeing a huge surge in the number of cases nationwide. There are reasons for this. One of them is the number of activities that can be performed outdoors is going to increase, especially in those states that have real winters with real cold temperatures, including parts of Texas, North Texas and West Texas. Also, schools have reopened, and even though they're keeping a close eye on schools, you all have seen the cases of schools that have opened in person and then shortly thereafter have to close because as soon as they open, a whole host of cases appear. That is likely to persist, and especially as schools are moving from remote teaching progressively to in-person teaching. So the Houston Independent School District is supposed to start in-person classes this coming Monday. It is one of the largest independent school districts in the country, and we will see how that goes. It's something to keep an eye on. Other reasons to expect a surge is that typically in the winter, the late fall to winter months, any year, that's also known as respiratory infection season. So colds, common colds increase, the flu is coming, and that's a concern as well, because if you're adding flu and COVID and common respiratory infections, then you're adding to the burden. So let's see what's around the corner in terms of the data we have today. Next slide. So worldwide, you see in red the peak I've already shown you a couple of times in the US. People talk about a first, a second, and a third wave. I personally think we are still in the first wave because we never really got back to baseline in any of these. But it doesn't really matter what you call them. You see that we have had two peaks so far, and the rates are increasing in the US again. Now, we had been looking to Europe as a model of how to control the virus. They had implemented some very strict lockdowns in some countries and I wouldn't quite say draconian measures as they did in China, but much stricter than in the U.S. and making them mandatory, etc. And that worked for a while, but look at what's happened since about the beginning of August. Rates in Europe, and this is the European Union, are now at the same level, and as of yesterday, even a little bit higher than in the U.S. This is the number of cases, new cases per million residents, the daily average. So a lot of the European countries are now going back and implementing, pausing all of their reopenings and implementing lockdowns again and curfews at night and things like that. France just implemented a 4-week curfew at night for all of its citizens. On the other hand, we have other countries like Canada, who's also starting to see a surge, although at a much lower level than us. But countries like Australia have managed to do a pretty good job the whole time. They were very strict at implementing lockdowns and other measures, and they will lock down entire cities if the cases start rearing their head in a particular hotspot area. But they've got their situation under control. Now we have to remember they're in the southern hemisphere, so it's their summer, their spring right now, and that is ongoing, and so their respiratory infection season has not hit yet. Even though COVID doesn't appear to have a seasonal pattern, Australia, like other countries, would be expected to have increases in respiratory infections as in their fall and winter months, which have already passed. And we can learn from that experience. Next slide. So this is the situation worldwide. If we look at the New York Times today, we see, as I was saying, that we may be climbing toward a third peak, and this is by looking at the number of daily cases in the U.S. In July, in mid-July, the U.S. had an astounding number of new cases per day at around 67,000 new cases per day. We managed to get that down to around 30,000, which is not great, but it's a lot better than 67,000, and things were looking pretty good. But over the last 2 weeks, they've started to creep up again. And just 2 days ago, the number of new cases was back up to 52,000. So this is worrisome. Next slide. And it's worrisome not only because it is affecting the average numbers, it's also affecting the distribution of these new cases. So, when you read the paper, sometimes over a period of weeks, you see that the states that had it under control now don't have it under control. States that were having alarming increases now have it under control, and it keeps going back and forth. But if we look at the trends and the geographic distribution of where the new cases are, and we map them to the peaks that we've had so far, and then to today, we see something that is concerning. So the April peak was based on cases occurring primarily in the New York area, in the southeastern United States, and in Louisiana. Not even Texas was much on the map at that point. When we hit the mid-July peak, the distribution was still predominantly on the East Coast, and now the Gulf Coast area, including Texas. But it was also spreading to a lesser degree in the western states. And now look at just as of October 13th, still heavily based on the east and southern coast, but now it's the entire Midwest. And so these are the trends. And this is what is worrisome. Next slide. And in Texas, if we look at our colleagues here at the UT School of Public Health's dashboard, the Texas Pandemic Dashboard, they've been using the data to predict where things are likely headed over the next 2-week period or so. And you see that as of yesterday, they predicted that over the next couple of weeks, we're going to start seeing increases in cases in Texas as well. Their band of confidence, the gray area is wide, but the average line predicted line is going up again. Next slide. So I talked about some of the reasons for that we need to be concerned that we may be on the verge of another surge. I want to focus in now on a particular situation, which I know is interested a lot of folks, and that is the coincidence of flu season, traditional flu season, with with COVID, and what is it going to look like? So currently, here's what we know. Next slide. Okay, so we need to go over some basic principles. So how contagious is the virus, the COVID? And I've talked to you about the RT or R naught value, and that number is based on how many people a single infected person can in turn infect. So we need to compare flu and COVID. The flu on average has a reproduction number of around 1.3. That means every person with the flu can spread it to a little more than one person. Next slide. Measles, in comparison, which is a highly contagious disease, if you are around measles, your chance, and you've never had it before, your chances of acquiring measles are huge if you're around a person that is actively infected with measles. So its R naught value is 18. In 2009, we had the flu pandemic of 2009, and the R naught value was a little bit higher than the regular flu, 1.5. So COVID, if you don't do anything, if you don't implement any type of protective measures, no social distancing, no masking, no community measures, that virus by itself has an R naught value of around 2 to 2.3. That's unprotected. That means every person with COVID, infected with COVID, can spread it to more than 2 other people. However, if you implement the various measures that we hear constantly, universal masking, physical distancing, avoiding large crowds, and washing your hands and practicing good disinfection practices, we can reduce that R naught to the values that I showed you before, even to below 1. So that's what the goal is. But when they are uncontrolled, if you have flu with an R naught of 1.3 and COVID with an average of 2.3, the two of them may act synergistically unless protective measures are implemented. Next slide. So a little bit about the flu. The flu is, in contrast to what we're seeing with COVID, the flu is a seasonal virus. We all know that we start getting our flu shots in September, and that the flu starts hitting our area typically in, can we go back, please, to the previous slide? Yeah. So it typically starts hitting our area in November, and then increases November, December, January, and then around February, sometime towards the end, it starts decreasing, and then we wait for another season. What we have on this graph is the last several years of flu season. Previous slide, please. The last previous several years worth of flu cases, and you know that they map nicely one on top of another. This is a clear-cut seasonal pattern. So it begs the question, if we are now entering the flu season, what might that pose? I mean, remember that we do know that that the flu has its own mortality. It does affect the extremes of age. People who are old or very young children under the age of 2 years are more susceptible to having complications for the flu, and their mortality rates are high there as well. So let's look at the data. And there are pros and cons to this. Next slide. So there's good news and bad news. One is that if we do face a combined wave of both the flu and the COVID virus hitting the U.S. during what I think can be safely called the worst public health crisis of our time, and if that is coupled with lax safety precautions, we may be in for trouble. Both of these viruses can cause complications and death. It is true that some people are more susceptible to those complications and have a higher risk of death. With COVID, it is especially the elderly and people with pre-existing chronic diseases such as lung and heart disease or diabetes. For flu, it is typically the elderly, also people with underlying comorbidities, and the very, very young. In contrast, COVID, the very, very young, the mortality rate's very low. There are cases, and a lot of these cases have been described in China, of co-infection occurring. That means people who have at the same time both active COVID infection and active flu. We think this is unusual, but it has been well described, so that's a bad thing. And again, those vulnerable to either of the two infections stand to be affected most severely. Next slide. Next slide. Yeah. However, there are some reasons for optimism So we do know that for both viruses, strictly adhering to proper PPE and the safe precautions that our public health agencies can have been promoting consistently may lead to substantial reductions in both infections. As a matter of fact, we can look at Australia. Remember, Australia's in the southern hemisphere, so their flu season is already pretty much gone. And what they saw in Australia is a reduction in confirmed flu cases of around 70%, which is phenomenal. It's phenomenal. Unfortunately, because they had so few flu cases, they aren't able to tell us how well this year's flu vaccine is going to work because they didn't have enough cases. Usually we rely on the Southern Hemisphere countries to tell us how well it's working. Then, we could extrapolate that to our flu vaccine here in the U.S., which is based on their findings. However, Australia's community measures to protect people from the spread of the virus are much stricter than in the U.S. Another good point is that there is treatment for both infections. For the flu, we have a flu shot that, even though it's not 100% effective, it can be in some years substantially effective. But even if you do get the flu, whether you had the vaccination or you didn't, we also have treatment for flu with Tamiflu, for example, Ostelmavir, and some nasal flu prophylaxis and treatment as well. For COVID, we don't have any specific treatment to cure the virus, and as we know, we don't yet have a vaccine, although the work in progress is very promising, that we will have an effective and safe vaccine relatively soon. There are some treatments, at least for severe COVID cases, have been shown to alter the course. So things like steroids or remdesivir and possibly plasma antibodies are showing some benefit in treating patients. Typically, it's going to be the patients with the most severe cases. And for both flu and COVID, and based on prior experience with all vaccines, we know that if we are able to achieve mass population vaccination, that can further decrease the burden of disease and get us closer to what everybody's been hearing about on the news, which is the attainment of herd immunity. But typically for herd immunity, we're looking at levels in the community of around 70 or 80% of the population being protected before the remainder of the unprotected population can benefit from that protection. If we did not, right now we don't have a vaccine, and so if we look at the prevalence of people who have had COVID already and have a certain amount of immunity because they had it, it's nowhere near that 70%. At best, it's around 10% in those countries that have conducted community-based seroprevalence studies. Next slide. Okay, and now just very quickly, and more as a reminder, because I think all of y'all have heard of many of these tests already, but sometimes it's confusing because you hear about PCRs, you hear about rapid tests, you hear talk about antibody tests. Let's just do a very quick review and then I'll open it up to questions. So next slide. So the testing options that we have, go ahead and click through. Yeah, there you go. Keep going. Okay, so back. One slide. There. Okay, so in general, tests either measure the presence of virus or parts of the virus, or they measure the body's response to the virus. Those tests that measure the virus are subdivided into two types. One that's called the PCR test. Some people call it molecular test. These test for the actual genome sequence that is specific to the COVID virus, which is SARS-CoV-2. And then there are other tests that just test for some of the proteins that make up the virus, but that could also be present or not present in other viruses as well. Antibodies reflect the body's response to an infection with the COVID virus. And so it's what our body develops. And typically these are proteins, but they are proteins that we produce. They don't reflect the virus itself. Next slide. So The testing up the problems with the PCR. Looking now at the viral testing options, the most accurate test out there is the PCR test. This is the one that involves actually taking a deep nasal swab, what we call a nasopharyngeal swab, and then sending it to a specific lab. It's not something you can plug into a machine right there in your clinic and get an answer in a few minutes. And it is the most accurate in terms of sensitivity and specificity because it checks for the actual virus, the actual SARS-CoV-2 virus in your body that is present at the time that you test. Antigen tests, however, only check for certain proteins found on the virus. That allows them to be what we call point-of-care tests. These are tests that can be run in a machine, sometimes even in a clinic, and you get an answer within a few minutes. They both have their pros and cons. Next slide. The antibody is always a blood-based test. And so it checks for the body's response, as I was saying, which means it's checking for past exposure to the virus. And if you have antibodies, if you've been able to generate it and they are detectable, that simply tells us that at some point, generally in the past, you have had the COVID infection, even if you weren't aware of it. Next slide. So pros and cons of all of these tests. The PCR test, which is, again, the best test available, the cons are that it involves this deep nasopharyngeal swab, which can be uncomfortable. In some cases, especially when they are performed through commercial labs in clinics, so the clinic gets the swab and sends it off to a national commercial lab, it may take several days to get back. And we have had several instances of problems with some of the better known national labs around the country because they were overwhelmed with the volume of tests that were submitted, where I remember in March having to wait in a few cases up to 2 weeks. Well, obviously, getting your result 2 weeks later is totally useless, both from a contact tracing standpoint, both from a treatment standpoint. It's just more or less anecdotal. So it's now that same test in other centers can be obtained within a few hours. So for example, at UTHealth, the tests that we do, which are sent to our pathology department, I can get PCR test results back in about 6 hours and certainly within 24 hours. So that's important because I can make decisions based on that quick turnaround time. And again, the PCR is the best test. It's the most sensitive test. Next slide. The antigen test also requires this deep nasopharyngeal swab, although I can tell you that some pharmacies, some large national pharmacy chains, are asking the people that show up to be tested to obtain their own nasal swab, and they're not going the full distance all the way deep because it's hard to do it on yourself, right? So they are getting just sort of what we call anterior nares or anterior nose samples. There's a downside to that in that you may not get enough specimen or enough virus on the specimen, so that leads to false negatives. But it does have some utility. It is less sensitive than a PCR test, but if it is positive, you can be pretty sure it's positive. So, false positives are less common, but false negatives are the concern with antigen tests. And again, the advantage is you can get the results back within minutes, some of them within 15 minutes to hours. Next slide. And as for the antibody test, again, it doesn't tell you if you have the infection at the time of testing. It tells you if you have had it in the past. There's for other infectious diseases, having detectable antibody is synonymous with having developed immunity to that infection. Some of that immunity may be short-lived. So, for example, with the flu vaccine, we know that it confers immunity, but since the virus changes its characteristics every season, we need to get revaccinated every season because that immunity only lasts one season typically. For others, like measles, once you've got the immunity to it, it is lifelong. Well, with COVID, we really don't know yet. We don't know what a high antibody level means. It is likely that people who have had, and I would say I'm almost 100% certain of this, that people who have had the infection are left with some immunity. And the reason I'm able to say that is because out of the nearly 40 million cases in the world, only a handful, and when I say a handful, I mean a handful, 5, have been reported in the literature as getting the infection again. So reinfection, which at this point in time, with about 6 to 8 months of experience, appears to be very, very rare. Now, we don't know if that's going to change in the future because that immunity may wane over time. We do know that sometimes antibody levels disappear. But when they decrease or disappear, we don't know if that means that you've also lost the immunity. There are some infections like hepatitis B infection where you get the shot, you can measure antibodies, but over a period of several years, those antibody levels disappear, and yet your immunity persists. So the jury's still out. There is likely to be immunity. That's a good thing from having had the infection, but we don't know how long it lasts. And that's also going to impact the vaccine because right now, if we do develop, or once we get that effective, safe vaccine, we don't know how long the immunity conferred by the vaccine is going to last. Next slide. I think that was my last one. Yes. Okay, so we still have about 15 or so minutes for questions, and I'd like to open it up, please.
Thank you, George. So we'll wait a little bit here for people to type in any questions. I'll go ahead and throw one at you. Just to touch a little bit further on what your comments on the vaccine development. We heard in the news a couple of trials have been put on suspension. Could you talk about that? And if you could look into the Delclos crystal ball, kind of comment on when you think something might be coming out.
Right. Okay. So remember, these are we're talking about. So when you test a vaccine, there are different phases of research, right? We have a phase 1 in which a very small number of healthy human volunteers are tested. Then a phase 2 and a larger number of healthy people predominantly are tested and compared to people who don't get it to see if it was safe and effective. And then phase 3 clinical trials, which are the ones that we are interested in, are the very large scale trials where thousands, if not tens of thousands of people are tested with the vaccine and others are not tested. And we wait to see if A, it's effective as compared to people who don't get the vaccine, and B, whether it is safe. In a phase 3 clinical trial, the methods that are followed are very, very strict. Because the jury is still out on how safe the vaccine is, pretty much any unexplained illness that arises in a participant in the study may cause that study to be put on pause. That's the way it's supposed to work. It's over an abundance of caution. They stop the trial, they examine that person and see if what they have could be explained or attributed to the vaccine or not. Remember that when they stop the trial, they typically don't know yet if that person was one of the ones who received the vaccine and one who didn't. So there have been, the first trial was the AstraZeneca trial in the UK and also in the US that was stopped because one person developed a case of what's known as transverse myelitis. After they looked at everything, they decided in the UK that it was not connected to the vaccine, and they resumed that trial in the UK. But in the US, it has not restarted yet. They're still putting it on hold. Similarly, the Lilly trial of the monoclonal antibody was just put on hold a couple of days because somebody developed an unexplained illness, and all we know right now is that it is an unexplained illness. But that's the way it's supposed to work, because you don't want to, because we don't know about the safety profile completely, you stop it at any point when there's something that you can't explain. Now, that doesn't mean that if a person gets a cold, who's a participant in the study, that they're going to stop every study every time somebody gets a cold. But if there's something that is not clear or unexplained, they'll stop it. That's the way it's supposed to work. As for predictions, I do think we're going to have some answers by the end of this year in terms of availability of the vaccine for the community. I think that's going to lag several months. Not, because even though pharmaceutical companies are already prepared to start cranking out whatever vaccine is accepted, we're talking about hundreds of millions of doses that are going to be needed. And that's going to require some careful thought in society as to who gets it first. Do we vaccinate people in nursing homes first? Do we vaccinate healthcare workers who are there every day dealing with these patients? So there's going to be the National Academy of Sciences has come out with a framework for prioritizing vaccine, and it's a very interesting read. They've approached it in a different manner than they typically approach studies. Typically, National Academy studies and similar organizations, they'll go with the science first, and then they'll let the science drive, and then they'll bring in ethics and things like that. This group actually started the other way around. Their framework starts with ethical questions and ways to achieve equity, and then they brought in the science, and they develop a series. They're proposing a series of phases between who should get it first, all the way down to the phase where the entire community is able to get it. I do think that sometime around the middle of 2021, hopefully we will have gotten to the point where community availability of the vaccine is really starting to crank up.
Great, thanks. We have a question from Rita D'Angelo, and she asks, what is the false negative rate on the antigen rapid test? And then we have some follow-up questions on age distribution after that.
Right. So the false negative rate there are a whole bunch of antigen tests out there, but for the one that I'm familiar with, which uses the Sophia machine, it's around, so the sensitivity is 88%. So that tells you the false negative is going to be around 10 to 15%. But I'm glad you asked that question, because sensitivity and specificity are indicators of the effectiveness of a test, of the functioning of a test, when it is used under ideal conditions. There are a number of other factors that have nothing to do with the test and how good it is itself that are independent of that. And so things like, if you don't collect the specimen correctly, if you don't get enough stuff on the specimen, if you don't transport that specimen correctly, if it sits around in the lab before it's analyzed, all of these factors also influence the false negative and false positive rate, even though they're not the intrinsic characteristics of the test itself.
We have a question from a friend over in Denmark. Denmark is now seeing a increase in cases, and they ask, if you have any age analysis, and they say in Denmark we have many more younger people testing positive than during the first wave.
Yes, and so I do have those data. I can't show them to you today, but one of the things that we noticed was, remember what I said at the very beginning, the cases are going up in Texas, but hospitalizations and death rate are going down, and our death rate has been very, very low. That is attributable to two things. I think we've learned a lot more from the standpoint of medical care. We now have protocols that we treat with, when at the beginning in March and April we were sort of shooting in the dark. But I also think it's because the elderly population is doing an excellent job of following safety precautions. They are isolating themselves, and that is working. So they have a very low incidence of disease, and they should, because if they get the disease, as you correctly note, once you are 65 or 70 or older, your chances of death skyrocket. At the same time, so then that begs the question, well then, if they're not getting the cases, who is? And so what we saw, at least in Texas, and I would say in the U.S. in general, and we are seeing this at least in Spain, because I'm more familiar with the data from Spain, the surges in June and July in the U.S. and in Texas were largely driven by 20 and 30-year-olds. And and we are still seeing that now. As a result of a lot of things, reopening in the U.S., there were several holidays in the summer, in addition to it just being the summer. The relaxation of restrictions on restaurants and bars that are largely attended by people in their 20s and 30s, especially bars, large gatherings and parties in college campuses as schools and universities reopen. All of those are driving that age distribution. And I expect that as the elementary and middle schools reopen, that age distribution may continue. It'll stay high in the 20 and 30-year-old, but it'll also start shifting downward towards the middle school and primary school age children.
Okay, I've got a couple more questions that were entered. Just to kind of follow up on the distribution, and then Justin, I'll go to your question next. Daisha asked, the distribution was low in April, and could that be due to the availability of testing, and also the increase in distribution that can be related to controls in the state, some being more open than others?
So yes, I mean, yes to both parts of that question. So in March and April, if y'all remember, it was, the complaints were constant that there was not enough testing going on. We had a lot of trouble. Just to give you an idea of how bad it was, in March and April, through our employee health clinic, we initially were restricted to 15 tests a day. That's 15. And then it increased to 25. And then it increased to 75 per day. And now we have unlimited number of tests. So certainly the availability of tests may have, and probably did, result in an undercounting of cases in March and April. However, they probably did not result in an undercounting of cases that required hospitalization, because those folks go to the hospital if they're really sick, and the hospitals by and large had tests available and sooner or later were able to administer to their patients. And yes, the surges in the U.S. are, I think, largely tied, and I don't want to get political here, but they are largely tied to the lack of uniform and consistent messaging from our public health authorities, and the lack of national measures. In Europe, when it worked, the national measures were pretty strict, and they were followed everywhere. We don't have that. We have a tremendous variation state to state in the degree to which states open, don't reopen, enforce masking, don't enforce masking, et cetera. And that certainly contributed to the numbers we saw in the U.S.
Okay, and another question from Justin. If you are in close contact with a confirmed positive case, when should you get a test to have the least chance for a false negative?
So that's a great question, Justin. And so if you've been exposed, if you have a confirmed exposure and you're not feeling any symptoms, then the earliest you should test is at day 5 from that last exposure. And the reason for that is because it takes a few days for the virus to start replicating in your body and reaching a sufficient level to where it's detectable. At 5 days, that represents the median. That means 50% of people who have the infection will turn positive. And it peaks at around day 8. So that window between day 5 and 8, if you are asymptomatic, is the ideal period to test. If you test after day 10, then the problem becomes a different one. You may have already gotten over your infection, and yet you still remain positive, but you're no longer contagious, so it's less useful. However, if at any point after an exposure you develop symptoms, even if it's on day 3 instead of 5, you get tested when you develop symptoms.
All right. Outstanding presentation, George. I love your slides.
Thank you.
Very nice information. So I don't see any more questions on here. We're doing great on time. I have 9:57, and our next speaker is scheduled to present in